స్త్రీలు కూడినప్పుడే జగత్తంతా కూడాను ఒక పవిత్రమైనటువంటి దేశంగా రూపొందుతుంది.
It's only when the women get together that the whole nation becomes something exemplary.
ఈ స్త్రీల యొక్క సంఘము ఎంతనో గొప్ప విలువను సంపాదించింది.
So this society of women lends it a lot of dignity.
ఇటువంటి తత్వమును ఈనాటి పురుషులు కూడాను గుర్తించడానికి ప్రయత్నించడం లేదు.
So men should make an effort to understand this value in women.
దేశమును కూడాను హస్తగతం గావించుకునేటువంటి శక్తి కలిగినటువంటి స్త్రీలు ఈ స్త్రీలు.
These women are those who can really do such things in the world.
స్త్రీలు కేవలం సామాన్యమైనటువంటి యొక్క బానిసలుగా భావిస్తున్నారు అనేక మంది పురుషులు.
Men think that women are just subordinate to them.
కాదు కాదు.
It's not so.
వారు తలంచినప్పుడు జగత్తునే ఒక మూట మాదిరి కట్టగలరు.
When they just think they can just bundle up the world.
అటువంటి శక్తి సామర్థ్యములు కలిగినటువంటి స్త్రీలను మనం ఈనాడు చులకన చేయటం చేతనే మన గతి ఈ విధంగా మారిపోతున్నది.
It's because we're belittling such women who can do such tremendous stuff. The world has come to this state
స్త్రీలు
today.
సాధించలేనిటువంటిది లేదు లోకంలో.
There is nothing that a woman cannot achieve.
అలాంటి స్త్రీల యొక్క తత్వము మనం దినము కూడాను గుర్తించి వారు తగినటువంటి ఉత్సాహమును కూడాను కల్పించి వారికి తగినటువంటి సమాజం లోపల తోడ్పాటు గావించాలి.
Recognizing this quality in woman, we will have to give her support and try to encourage her and see that she becomes the pillar in
అలాంటి
society.
ఎంకరేజ్మెంట్ ఏ మాత్రము చేయటం లేదు స్త్రీలకు.
The women do not get encouragement at all.
ఏదైనా ఒక సత్సంగంలో ప్రవేశించినారా అంటే ఈ పురుషులకు దానిపైన కోపం కలుగుతుంది.
If they go to satsang and become angry,
వారి స్వార్థము వారి స్వప్రయోజనముకి మాత్రమే ప్రయత్నిస్తున్నారు కానీ స్త్రీల వల్ల జగత్తునికి ఎంత ఉపకారం కలుగుతుంది, ఎంత పవిత్రమైనటువంటి మార్పు పడుతుంది అనేటువంటి సత్యాన్ని వారు గుర్తించుకోలేకపోతున్నారు.
they're only thinking of their own selfishness or the self-comfort. They're not able to realize that through women alone they can progress into
చాలా వరకు స్త్రీల యందు స్వార్థరహితమైనటువంటి హృదయం ఉంటుంటాయి.
Women have got a heart which is devoid of selfishness.
దయా ప్రేమల చేత వాళ్ళ హృదయం నిండి ఉంటాయి.
Their heart is full of compassion and kindness.
పిల్లలను పోషించేటువంటి విషయం లోపల ఎంతనో జాగ్రత్తగా ఉంటుంటారు.
In bringing up their children, they are so careful.
ఒక్క క్షణమైన కూడా భర్త సహించుకోలేడు.
Even one moment the husband cannot
కానీ ఆ
tolerate it.
పిల్లలను పోషించేటువంటి విధానంలో రాత్రింపగలు ఎంతనో పాటుపడుతుంటారు.
Night and day the woman will strive to look after her child.
ఆ పిల్లల యొక్క ప్రవర్తనకు ఎన్నో విధమైనటువంటి ఏర్పాట్లు కూడా చేస్తుంటారు.
And she will always support the child in many of its actions and thoughts.
My humble pranams to my dearest Swami. Om Shri Sai Ram, everyone. Welcome to Sai Illumination series. These series are inspiring sessions with speakers within our region who have received guidance from Swami both in person and omnipresent, including in their professions and personal life, and will be sharing their experiences with us. We are indeed delighted to have such inspiring sisters within our region. Swami says the secret of perfect health lies in keeping the mind always cheerful, never worried, never hurried, never borne down by any fear, thoughts, or anxiety. You may wonder why I'm referring to such health-related quote from Swami today. We have a Sai sister with us today who will share her journey with Swami, inspire us, and educate us on topics related to gynecology. Without further ado, I would like to call our regional female YA coordinator, Ahimsa Govinder, to introduce the speaker. Thank you.
Thank you, Pavitra. Sayam, everyone. I'm Ahimsa. Nice to see you all today. And it's my pleasure to introduce Dr. Panneerselvam for the Sai Illumination series this afternoon. Priya is an obstetrician and gynecologist. She's from the Bay Area and is working at the county hospital where she trains residents or doctors in training and cares for the underserved. She was fortunate to grow up in Swami's fold and went through the SSC program from Group 1. As a young adult, she has been involved with several service projects, including Project Pride, a computer literacy class for mothers in rehabilitation. She is the product of a single parent home, and the credit for where she is today goes to her father. Saram.
Sairam, everyone. I am going to start by sharing my screen and sharing my slides. So give me one moment. Okay, can everyone see the first slide? Excellent. Well, Sairam, everyone, my name is Priya. I want to start out with a humble offering. I offer myself and I offer this work at his lotus feet. Sairam. Okay, well, I am first and foremost very grateful to be here with everyone today and grateful for this opportunity. I would like to ask the audience to participate today. So if you are able to put on your videos, that would be awesome. And I wanted to start with this photo. Has anyone ever seen this photo before?
No.
If Sai is the only person participating, it will make me very sad. So I hope the rest of you can chime in as we go along. This photo is actually very special to me. I saw this many, many years ago at a retreat when I was a child, and I searched and searched and searched for this picture. I could not find it anywhere for years. And then one day in one of the darkest days of my residency program, this photo popped up during some talk. And I remember thinking, I need to screenshot this. This is like the photo. It has so many beautiful photos of Swami, so dynamic, it's so powerful. My dad thinks of it as like, he looks like Brahma. And when my dad always talks about my profession as an OBGYN, he talks about how you are somebody who helps give life like Brahma. So it's very powerful to me, very pertinent to what I do. All right, so a little bit about me. My name is Priya. I'm from the Bay Area. I grew up here, part of Central San Jose Psi Center since the age of 6. And I am back now and have been here through Group 1, Group 2, Group 3, and YA activities. I am a doctor of osteopathic medicine. It is the same thing as an MD, except we learn a little bit more of a holistic approach. And so we also do a little bit of manipulative medicine, like musculoskeletal issues, chiropractor, we can crack your back kind of thing. So I did my medical school at Pacific Northwest University in Washington State. Then I did my residency in Ohio at Doctors Hospital, which is an MD and DO certified place. And then I was a faculty with UCSF Fresno campus for about a year, missed my family, so came back up to the Bay Area, Santa Clara Valley. This is a county hospital that I work with. We serve the underserved. All of our patients either have Medicare, Medi-Cal, or no insurance. And I also train residents here. There's an OBGYN training program here. My goal is to provide holistic, compassionate, comprehensive care to my patients. I believe every woman, regardless of your race, your socioeconomic background, deserves excellent care. So that is why I work with the county hospital. Now, today, I want to acknowledge we as Indians, most of us, we as Psi Center folks, we as a community are a little bit quiet about women's health issues. So today we're going to be talking about some issues that maybe there isn't a platform for, and I want to make sure that everyone has the opportunity to learn, be educated, enjoy, and walk to your doctor's office with the confidence of, being able to say, hey, I have this issue, help me. I also am hoping everyone participates today. We have a bunch of questions in the slides. So I want everyone to learn something. And remember, this is a safe space. There is no judgment here. It is recorded, but at the end, we can stop the recording when we go through questions, okay? Swami is within every person here, so let's have some fun today, okay? Okay. All right, so my first question is, what is an OBGYN? Does anyone know what OB stands for and what GYN stands for? Feel free to give any answers.
Obstetrics and gynecology.
Yes, excellent. Obstetrics is the study of or the taking care of pregnancy, of babies, prenatal care, delivery, vaginal delivery, C-sections, and postpartum care. Gynecology, GYN, is women's health. So when you go to see your doctor in the clinic, medications given to you, some support, surgeries. So the surgeries we do are, we remove the uterus, we remove masses in the ovary or in the tubes. We do sterilizations, we look inside the uterus, it's called a hysteroscopy. We remove fibroids, we do vaginal surgery, we even do abortions. So I want to do a very quick anatomy review. Can everyone see my pointer on the, okay, excellent. I'm going to start with this bottom photo. So this is the pelvis. Now, all your organs are inside your pelvic cavity. This is the uterus. It is comprised of muscle. So that's kind of the outside, that thick wall. The inside is the endometrium. The endometrium is what grows every month and sheds every month. So that's where you have a period. These are the ovaries, and then the fallopian tubes. The ovaries are what produced estrogen. And then down here at the base of the cervix, at the base of the uterus, you have the cervix. This is the vagina. So this is the pelvis from a frontal view. Now, this is a person with their legs open. On the outside, you have the vulva, which is the skin, labia majora, labia minora. Then you have the clitoris at the top. You have the urethra. The urethra is where urine comes out of. And then you have the vagina, and then you have the anus. This is a fun photo of a mannequin from a simulation we did with the residents. I think the mannequin's name is Anna. I'm not 100% sure about that, but this is a way we teach using a lot of our high-tech gear. All right, so now this is another, if everyone can participate, that'd be great. We're going to start at the beginning of a woman's journey. What is menstruation? So what is the average range, age range that menses starts, and what is a regular cycle, and how long should a period last? Can anyone answer any of those questions?
I guess it starts, well, earlier it used to start about 8, 13 or 14, but now I guess it's about, I've heard that it starts about as early as between 10 and 12.
Yeah, absolutely. Absolutely. And then how long should a period last? What's a regular cycle? Any ideas?
About 4 days or 4 to 5 days, maybe.
Yeah. And then what do you think are some things that can, and not just Auntie, anyone can participate. What do you think are causes for heavy periods or abnormal bleeding?
Could it be due to cysts in the ovaries?
Ovulatory dysfunctions can absolutely lead to irregular bleeding. Absolutely. PCOS is part of that. Absolutely. And then how long can I leave a tampon in? Any ideas?
4 to 6 hours.
Yes, excellent. And then what are some alternatives to pads or tampons?
There are a lot of reusable things like reusable pads, reusable menstrual cups,
Yep,
period
absolutely.
underwear.
Absolutely. And then what is menopause and what is the average age of menopause? Any ideas?
I'm believing 45.
Average age is about 51 to 52 in this country. And again, that's just the average. For different women, it's different times. Some people, it happens very early, some people it happens later. So menarche, which is the start of menses, the average age around 10 to 13. It is getting younger and younger and younger as time goes on. Regular periods are every 21 to 35 days. They can last anywhere from 3 to 7 days. There are a lot of ranges here because every woman is different. You can track your periods on an app or with a calendar. Remember, anything that is irregular, anything that is heavy, anything that is painful needs to be discussed with your OBGYN. Now, there are many things that can cause abnormal uterine bleeding. You know, polycystic ovarian syndrome or ovulatory disorders, absolutely. Other things are fibroids. Those are growths inside the uterus, polyps, another type of growth. different type of tissue. Pregnancy can lead to abnormal uterine bleeding too. I've had patients who've had periods throughout and they didn't even know they were pregnant. Endocrine dysfunction like thyroid issues, elevated prolactin, those can cause abnormal bleeding, and cancers can cause bleeding. So anything that is abnormal, please, please, please go to your doctor to get it checked out. Like we said, you can remove a tampon every 48 hours. Consider cloth pads, period underwear if plastic pads are uncomfortable. Sometimes the disposable, A, can be really expensive, B, can cause irritation on the vulva, the skin. So cloth pads, period underwear, those tend to be really good options. There's also like the menstrual cup that you can place. It is more sustainable. Needs to be sterilized before you use it though. And then menopause is around age 51 to 52. Menopause is when kind of the ovaries stop functioning, so you don't have any more estrogen on board through the ovaries. Okay, so we're going to be kind of talking back and forth about medical knowledge and then my personal experiences with Swami. So a little bit about my journey into medicine. Swami made himself very evident every step of the way in my journey. It was a very hard journey, a lot of sacrifices, a lot of frustrations, but he made it clear he was with me every step of the way and that he was the doer and I was in the right place at the right time, doing the right thing for me. When I first got into medical school, I got into one school and I had one interview. And I remember thinking, I am not going to do this. I am not going to make it. I'm not going to be successful. This is going to be horrible. I was so afraid and so freaked out. I got on the plane to do the interview. It was in Washington. And I started crying and I couldn't stop crying. And someone actually asked me if I was going to a funeral on my plane. And I looked at her and said, no, I'm going to my medical school interview. And in that moment, I knew, oh my God, I need to get myself together. So I pulled out this book that a friend had given me, and it was called Inspired Medicine. This is the cover here. It's just a random book someone gave to me, and I opened it up to a random page, and I read these 3 lines. He who appears to be nowhere, he is everywhere. He who appears to be disinterested, he is enjoying everything. He who appears to be doing nothing, he is doing everything. And it was like Swami just came up to me and turned off the faucet. Like he's just assured me, I'm with you. Everything is going to be fine. Stop crying. And in that moment, I was able to collect myself. I did the interview. Everything went well. I got in. Fast forward 3 years, it was time to apply for residency. And residency was a whole different type of beast. You see, you kind of have to look at all the residencies all over the country. And I looked at different programs everywhere. There was one program in Ohio that was highly reputable. It was a traditional DO program, but it was also MD certified. And they just did a ton of ultrasound. They did a ton of surgery. They were known for creating like the super generalist obstetrician gynecologist. So you could learn how to do vaginal hysterectomies, abdominal hysterectomies, everything. And I just thought, well, it's in Ohio. Do I really want to go to Ohio? And I showed up. I dealt with a lot of racism, a lot of difficulty. But then I went to one part of the hospital and I saw this symbol. And it's here on the right upper hand of the right upper corner. And you can see it looks very similar to our symbol. It has the Om, the wheel of Buddhism, it mirrors our Sarvadharma symbol. And in that moment, as much as I did not want to go to Ohio, I knew this is where I was supposed to be. And I knew he was putting me here for a reason. And that's exactly what happened. I joined that residency program. It was very challenging. I was the first person of color in like 10 years, and I struggled. I really struggled. But it was great training. And there was a point in time, my first year, I was a resident who got yelled at all the time. They hated me. I couldn't do anything right. And I wanted to quit. I was so afraid. I would walk into the hospital saying, Saidam, 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 Saidam. And I would pray all the time. One day in my second year, I walked into the hospital and I was told, hey, there's a patient waiting for you. She's having a little bit of bleeding. She's on the labor and delivery floor. We think she's going to deliver. We're not really sure. You should go check her out. So I walked up to that patient. I started talking to her. As I'm talking to this like 35-week laboring patient, her baby's heartbeat starts to tank, like into the 40s. And I looked at her and I said, okay, listen, this is not coming back up. We need to go for a stat C-section now. She looked at me and she said, okay, if this is what we need to do, we need to do it. We roll her back to the OR. The nurses start getting her set up and I start scrubbing, getting cleaned for the surgery. I walk into the OR and get gowned and gloved and they hand me the scalpel. And I thought, oh my God, this is my first stat C-section. All the while, sidearm, in my head, I make the incision, I get the baby out, the baby comes out like blue and limp, and I thought that baby was gonna die. It looked so bad. I hand the baby over to the NICU team and I'm yelling, sidearm, as I'm handing this baby over. And in that moment, I realized it was the first time in my medical career that I was praying for the patient and her baby and not for myself and not for them to not yell at me or, whatever. And that's when everything changed. That's when I realized I'm here to do his work. If I offer it to him, he will take care of everything. I also changed the trajectory of my career. Instead of going into, a regular Kaiser 9-to-5 job, I decided I'm going to help the underserved and commit to working with people who don't have insurance or who have Medicare, Medi-Cal. And I'm going to commit to teaching because no learner should feel the way I felt when I was a resident. No one should be that scared. That is not a healthy environment for anyone. So it changed how I looked at jobs at the end of my 4th year when I was trying to come back to California. And one of the only interviews I got that fit that criteria of underserved and teaching was at UCSF Fresno. And I know Fresno, no one really wants to be in Fresno, but it offered me what I was looking for. And I remember I had some doubts and my sister took this picture of this mural the day I had my first day on the job. She came, she dropped me off and she took this photo and it says health and unity in diversity. So it was another sign that Swami was with me and I was in the right place doing his work, his way. All right, so more questions for the audience. Let's talk a little bit about cancer prevention and healthcare maintenance. Can anyone answer this question? Is there a screening for ovarian cancer?
No screening for ovarian cancer.
Yes. Now, when should breast cancer screening start and how often?
Maybe at the age of 40.
Yes, perfect, 40. And then how about cervical cancer screening?
Age 21.
Yep. And then when and how do we scan bones for women?
Is that with a DEXA scan?
Yes, it is. It is with a DEXA scan and it is around the age of 65. So no screening for ovarian cancer. Breast cancer screening is perfect. You start at age 40. If you are the average risk woman, if you have higher risk, right, family history or personal history or something different, it's different. But for the average risk woman, you start at age 40. And you get mammograms every 1 to 2 years. It's imaging. You also, every time you go to see your doctor, typically for an annual, we'll do a clinical breast exam. I also will request every person here, know your body, know if anything is different, talk to your doctor. Cervical cancer screenings, that typically starts at the age of 21 until the age of 29 every 3 years. Once you hit the age of 30, we typically will go to 5 years because we'll do not just the pap smear, but we also do HPV testing. That is testing that checks for a virus that could cause cervical cancer. And DEXA bone scans start at age 65. Get your vaccines. Everybody get all your vaccines per vaccine schedule. Highly recommend every single one. And then colonoscopies, fecal occult blood testing that starts around age 45, age 50, depending on your risk factors. Okay, so a little bit about cervical cancer. We've kind of touched on this already. What is the most common cause of cervical cancer? Any ideas?
Is it HPV?
Yes, HPV. And then how can we prevent cervical cancer? I can talk a little bit more about that. So most cancers of the cervix are caused by human papillomavirus, or HPV. It is sexually transmitted. It can also cause oropharyngeal, anal, penile, vaginal, and vulvar cancers. Pap smears and HPV testing are screening tools that we use, and that's how we catch it before it becomes a cancer. Now, the HPV vaccine and condoms can prevent HPV and protect against it, but the most powerful thing that I think is the coolest thing is that HPV vaccine. It's called Gardasil 9. It can be given from the age of 9 to 45. Men and women can and should get it. It'll protect against all the high-risk strains of cancer, as well as genital warts. So highly, highly recommend this for everybody out there. Okay, a little bit about what you can expect when you go to see your gynecologist. So the pelvic exam is a good tool that we use to evaluate everything. Now, it's just some tips for everyone before you go and get your pelvic exam done. Urinate before. Remember, there are different types of speculums in different sizes. The speculum is the metal or plastic device we use. It is placed inside the vagina and we open it to view the cervix. And it allows us to kind of assess what's inside. So it's just a device we use to see. It can be a little uncomfortable. We tend to use a lot of lubrication to make sure that the exam goes smoothly. You don't need a pelvic exam every single time you go to see your gynecologist. However, if there is an issue and if we need to do an evaluation or you're due for a pap smear, this is what we will use. I consider the pelvic exam to have 3 parts. The first is visualization. So looking on the outside, making sure everything looks okay on the outside and looks normal and healthy. And then checking for things like, is the uterus starting to kind of fall a little? Is there a little bit of protrusion of the bladder, protrusion of the rectum? Very common after pregnancies and giving birth vaginally. Very normal. We just have to learn how to deal with those things and fix those things. The other thing I want to point out is when we place the speculum, it's not always a pap smear. It can also be just placing the speculum to look for visualization or collecting swabs for infection, like a yeast infection or things like that. And then the last part of the exam after we take out the speculum is the bimanual exam. 1 or 2 fingers go in the vagina and then a hand on your belly. And we kind of compress the uterus between our hand just to see the size, the mobility. And we check the sides of, we call it the adnexa, the ovaries and the tubes. Is anything abnormal? Is there any big cysts? Is there pain? So this is a good way to evaluate all of that. Okay, a little bit about birth control. So can anyone shout out some forms of birth control or contraception?
Condoms, pills, sponges.
Excellent, yes. And then what do you think the most effective form of contraception is?
Abstinence.
Yeah, that's 100%. Yeah, and nothing else is 100%. So here is a nice flow chart that we tend to use. So I've listed in order of like, how good is the birth control? Sterilization is one of the better types of birth control, right? Depending on how you get the sterilization done. I have a tendency when I do a sterilization procedure, I will remove the entirety of the tube. I don't burn. There's no such thing as tying. I just take it out because the ends of the tube are high risk for cancer and high risk for ovarian cancer. So I would rather just reduce that risk for my patients. LARCs, so long-acting reversible contraceptive devices like the intrauterine device IUD. There are 2 types, hormonal and non-hormonal. The non-hormonal uses copper. It causes inflammation and that's how it works. So I found a lot of my patients who say, oh, I want no hormones. They choose this, but then their periods tend to be a little bit more crampy or a little bit more bloody, heavy because it's inflammation. The other IUDs have progestin, which is a type of hormone to help mitigate multiple things that, prevent pregnancy, but also can help with heavy bleeding, depending on why you have heavy bleeding. Then there's the Nexplanon. It's a bar. It goes in your arm. It lasts 3 years. Depo-Provera, it lasts 3 months. Some patients say that they gain weight with it. It has been shown to increase appetite, but yeah, that's just one of the side effects. Then there are things like the pill, the patch, the ring. Take it every day, you use it every week, or you use it every month. And I think there's also a ring that just came out that you can use for a year. So that's another option. And then there are barrier methods like diaphragm condoms. I've actually never prescribed a diaphragm for a patient. You have to be measured, or even like just estimated measurements for a diaphragm. But it is a great form of, well, it's not a great form of birth control, but it is a form of birth control. All right, so a little bit more about my adventures in teaching. Some of these photos are really fun. These two are residents from UCSF Fresno, excellent residents. We did surgeries. These are giant uteruses we took out. You can see they're huge, caused a lot of issues for these patients, so we removed them. And then here in this bottom right corner, this is a mannequin. We're simulating a lab, like a postpartum hemorrhage, like patient is bleeding out after delivering kind of lab. So all the residents are there. Top right, we have, this is actually taken like last week. We just did a lab on how to do an abortion. Like it's called an MVA, manual vacuum aspiration, how to do it in the ER. And we simulated using dragon fruit. So I was in charge of that station. And this is one of our brand new residents. She just started July 1st. Yeah, and this is at Santa Clara Valley. And then this photo with the pink signs was a year ago when Roe v. Wade was being overturned. We, myself and some of the faculty protested this. This person is a gynecologist. She's a cancer doctor, cancer surgeon. This person is an RAI. She's a reproductive endocrinologist. And this person's also another generalist. One of my favorite memories with the residents that I work with it was actually at the end of last year, end of the academic year. I had a 4th year resident. She was doing a C-section. She was at the tail end. She was about to graduate, right? And I thought, oh, this is going to be a breeze. I have a 4th year resident doing an easy C-section. I just get to stand here. And so she gets the scalpel. She goes down to get to the uterus, makes her incision, puts her hand in, and she looks at me and she says, Panneer, I can't deliver this baby. It is too hard. And I looked at her and I said, what is going on? You're a 4th year resident. And then I said, okay, let me try. I put my hand in. I couldn't deliver the baby either. And then she looks at me and she tries one more time and she says, I think we need to tee the uterus. What does that mean? She's basically saying, we make a horizontal incision on the uterus. She's saying, tee it, like make a vertical incision now. That can cripple a uterus. That can make it so the patient can never have a vaginal delivery again. The consequences of that type of an incision on a uterus are detrimental. So I looked at her and I said, no. And I said, Sairam. I just said the word out loud. I put my hand in and then I delivered the baby. So it's kind of it was a good moment for me to A, learn some humility, and B, keep me on my toes. Just because I'm in a position where I get to teach doesn't mean I know everything. And the teacher of teachers is always teaching. So without him, I wouldn't have been able to get that kiddo out. Okay, so on to another topic, PCOS. What is PCOS and what are some options for treatment? Anyone, feel free to chime in.
Irregular periods.
Yes, irregular periods, absolutely. And then I can go to the next slide. So PCOS is a condition. It's kind of threefold. The first is irregular periods. The second is polycystic ovaries, which are seen on ultrasound. And the third is hyperandrogenism. What does that mean? It's an imbalance in hormones. So it means that there's just too much male, quote unquote, male hormone on board, kind of overtaking the quote unquote female hormones. So when that happens, there can be things like male pattern baldness, facial hair, cystic acne, just some, because that hormone is kind of more in the body. So those are the symptoms, right? Irregular period, acne, facial hair. The other part of this is insulin resistance. So this is kind of the part that has a long-term impact. It can mean that metabolically, there can be some, issues in the future, like hypertension, hyperlipidemia, or elevated like cholesterol and diabetes. So some of the ways, like the key ways that we work to mitigate those risks are lifestyle modification. So things like exercise, changing diets. And then when it comes to treatment, medication, we want to talk to you about your goals. If your goal is to have a baby tomorrow, we can't start you on birth control to fix your hormones, right? That's not going to work. So we do have medications to help women ovulate, so that they can get pregnant in this with PCOS. So just looking at these ultrasounds, this ultrasound at the top is a normal ovary with 3 follicles. So every month when a woman ovulates, what that means is a follicle bursts open and an egg comes out. And then the tube with its like finger-like protrusion sucks up the egg and it goes down the tube into the uterus. With PCOS, all these little follicles, they all look the same size. So nothing gets recruited to kind of rupture and, break free for an egg. They're all the same size. So a woman doesn't ovulate with PCOS. And that's why, again, kind of can be hard to get pregnant. All right. So I want to talk a little bit about pelvic ultrasound. This is something we use as a tool to help with diagnosis and treatment of a lot of our patients. On the left, we have a photo of a transabdominal ultrasound. So the probe is on the belly. You can tell by it's kind of wide probe. And we have some fat here. This is abdominal fat. And then we have the bladder. Bladder is anechoic. It's filled with fluid, and it allows for the ultrasonic waves to kind of travel through nicely and give us a nice picture of this uterus underneath. So you can see here, this is the outline of the uterus. This is the cervix. It's actually a very good picture for an abdominal ultrasound. I'm actually quite impressed. The truth is we don't often get pictures this good with the abdominal ultrasounds. So in all honesty, I know it is uncomfortable, but a vaginal ultrasound with the probe inside the vagina tends to give us the best pictures. So if your doctor recommends this, I would think it's worth getting. It doesn't tend to be that uncomfortable, but every woman is different. They will again use lubrication on that probe. So it goes inside the vagina. And as you can tell, this is the uterus, this whole thing. This part on the outside, the darker part, is all the myometrium, or it's the muscle of the uterus. The inside, that whiter part, is the endometrium, what we talked about before, the thing that grows every month and sheds every month. If this is thick, sometimes it means that, oh, maybe she's about to have her period. If this is thick, it might also mean, oh, there's a polyp inside, or there's a fibroid or something else inside causing heavy bleeding. So this is a great way for us to assess what is going on inside the uterus. Okay, next topic is a little bit sad, early pregnancy loss or miscarriage. If, we don't necessarily have to go through the questions with everyone here, but what are some common causes of miscarriage and symptoms of miscarriage in early pregnancy and treatments for miscarriage? I just want to say, for anyone who's ever experienced this, we are so sorry. This is a horrible thing to have to deal with. It is extremely common. 1 in 10, like 10% of pregnancies are miscarriages. It is never a woman's fault, never. It is usually due to things like chromosomal abnormalities of the developing fetus. So it's usually something that just happens. And it doesn't typically impact subsequent pregnancies. So oftentimes when a patient has an early miscarriage, I tell them, okay, have a period or 2. Also do some emotional healing, because this is a hard thing. This is a loss. And then afterwards, when you feel ready to try again, try again. But we want to make sure that this miscarriage is done with before we start trying again. When you have an early pregnancy, it's important to watch out for things like bleeding and cramping. Those can be signs of oncoming miscarriage. And then treatments, once a person has a miscarriage, we can always watch and wait and see what your body does. We can try medical things like pills to help contract and pass the fetus. And the third we can try is surgical, like we can remove the uterine contents. Just like, we did that skills lab with the dragon fruit, we can do something like that for you too. I put this photo of a rainbow here. Has anyone heard of a rainbow baby?
I have.
Yeah. Well, a rainbow baby is a baby after a miscarriage. So the subsequent pregnancy that is, turns into a healthy pregnancy. When I was a second-year resident in Ohio, I was the person doing C-sections. And one day I walked onto the labor and delivery floor. And when I, meet a patient, I always say, hey, I'm Dr. Panneerselvam. Are you having a boy or a girl today? And then they'll give me an answer. And then I'll say, okay, what's the name? And I introduced myself the same way with a patient in Ohio. And she looked at me, she said, well, I'm kind of debating either Claire or Priya. Those are the two names I'm thinking about. And I looked at her, I said, huh, that's interesting. And then she said, yeah, this is a rainbow baby. And I was on a support group for rainbow baby moms. And they suggested the name Priya because it means deer. And I just thought that was really cool. And I looked at her and I said, that is really cool. My name is Priya. And now there's a little white baby running around Ohio named Priya. So, I think rainbow babies are a beautiful part of what we get to do. Okay, now on to some obstetrical emergencies. This slide is basically just to say anything can go wrong at any time, in any way, ever. So literally when we are running labor and delivery and taking care of moms in labor, so many things can happen, from babies getting stuck in the delivery, baby's heartbeat's not looking good, we have to run back for a stat C-section, just like I shared with you with that, one patient. Patients can bleed after a baby is born. We have to intervene at that point. Traumas can happen in pregnancy, seizures, like uteruses can rupture. Like, remember I was saying, if we make the incision like a T shape, if that patient had gotten pregnant in the future, there's a risk that uterus can burst open. Just all sorts of bad things could happen at any time. When I was a 4th-year resident in Ohio, I was covering it's called Grant Hospital. It's in the heart of downtown, level 1 trauma center. When you're on nights, you are the only resident in the hospital. Like, I was the only person, the only OBGYN with an attending, and my attending happened to be like 90 years old. And we were covering the floor. It was a really busy night. All of a sudden, overhead, we hear this page, GSW +3. And I looked at the charge nurse and I said, listen, GSW? And she said, yeah, gunshot wound. And I was like, oh shit. So I said, listen, we got to run down. We took all our ultrasound equipment. There was a pregnant patient they brought to the trauma bay. She had a gunshot wound to her right hip. I did my assessment. Baby was still alive. It was head down. And then we talked to the trauma team and they said, we have an entry wound for the bullet, but we don't have an exit wound. So I said, okay, what does that mean? And they said, well, you need to deliver this baby and then we need to figure out where this bullet is. So we took the patient up to the OR, and in the OR is total chaos. Anesthesia is there, trauma team is there, and that's like 5-6 people. The NICU team for the baby is there. The OB team, my team is there. And, everyone's just standing and watching, because gunshot wounds in pregnancy in that area, it happens, but not that common, right? So I'm standing on the side of the table ready to operate. My attending is right across from me. And like I said, 90-year-old man, a very nice man, but still 90 years old. So I get the scalpel, get down to the baby. I put my hand in and I said to him, this is not right. This baby doesn't feel normal. And there was this weird tissue coming out and the head just felt like weird. And I kept saying, this is not right. This is not right. And he said, keep going, get the baby out. I got the baby out. The baby cried. And then I heard someone scream. And then I looked at the baby. The bullet had passed through the baby's skull. And all that tissue that I was seeing was brain. The baby was still alive. It lived for like 3 hours and the mom got to see her baby. But the miracle of this is that that baby saved her life. You see, when you're pregnant, right, you have uterus, vessels, bladder, bowel, all sorts of things in that area. The bullet didn't touch any of that. She could have died on the spot, but it went through that baby. So as sad as it was, a 15-year-old girl's life was spared. So that was a very interesting case, and that was probably my most stressful case of my life. Okay, so back to you guys. Go see your OBGYN. If irregular, painful, heavy periods, you think you might be pregnant, bothersome vaginal discharge, anything abnormal, go get it checked out. It could be a yeast infection. It could be something called bacterial vaginosis, which is just a shift in bacteria in the vagina. It just needs some medicine to be fixed. But if something is consistent, it needs to be really investigated because there could be other underlying factors there. If you are menopausal and you have bleeding, That is not normal. Once your ovaries are done, your uterus is done. So if you are bleeding, you need to go get checked out because there is a risk for cancer. If you have bleeding after intercourse, pain with intercourse, please go get checked out. Any lower abdominal pain, any issues urinating, any burning frequency, it could be a urinary tract infection. It could be something else. If you notice any lumps, bumps, abnormalities in the vulva, if you notice any breast changes, skin changes, lumps, bumps, nipple discharge, go to your doctor. So how can I improve my health now? Eat more non-starchy vegetables. So that's not potatoes. That's things like kale, cucumber, spinach, that's things with nutritious values, broccoli. And a lot of fruits have a lot of antioxidants. So like berries and things like that, like blueberries, that's good for you. And that's going to help prevent cancers too. Exercise. When I say exercise, that doesn't mean, run a marathon. It would be cool, but start slow. 15 minutes a day, 15 minutes every 2 days. I tell all my patients, whatever you can do will help. You want to build it up slowly. And you want to make a commitment. So if it takes time, that's fine, but make a commitment for your life. Drink plenty of water. Prioritize your own physical, mental, emotional, and spiritual health. Women, just like Swami said, right? Women are selfless, compassionate, give up everything for everyone else. Take some time for you too. That is incredibly important. I don't do it either. So something I need to work on as well. And if you plan to get pregnant, take a prenatal vitamin before you're pregnant. The neural tube develops like in the first 4 to 6 weeks of, pregnancy. People don't even know they're pregnant when the neural tube develops, and you need folic acid for normal neural tube development. So if you have folic acid and a prenatal vitamin on board beforehand, it'll lead to better outcomes. Also, before you get pregnant, kind of get your, health together if you can. If there's certain medications that are not good during pregnancy, try to get off of them before you get pregnant. Okay, I am about to conclude with a huge amount of gratitude, of course, to Swami. This is the altar on my mantle when I was in my residency. It has, of course, Swami, my mom, my family. Every step of the way, Swami was there for me. There are many reasons why I chose OBGYN: to advocate for women, to save 2 lives. It's the only specialty where we get to save 2 lives, not just one. But more than anything, it was probably my mom. My mom had ovarian cancer, and she was diagnosed with it at the time of her pregnancy with my sister. And so that was the biggest inspiration, I think, that pushed me into this field. And of course, all the sacrifices that my family made so that I could pursue my dreams. And I have to give a huge shout out to the furry friends, our dog Merlin, and I had a cat named Lamond. And just a quick thing about Lamond: when I went to Ohio, my family was like, "You are so sad. Residency is not good for your mental health. You need something to love." So I went to the shelter and I found this cat that was old. He was like 12. His owner had just died. He had all these health problems. And I just thought, you need love. I need love. You're probably going to die before I finish my residency. If I don't take you home, no one else will. So I brought him home with me. And I think Swami sent this cat. Like, he was my companion throughout my whole residency, throughout my first job in Fresno. He actually passed away as soon as I moved back in with my family. It was his way of watching over me, being with me when I was away. So anyway, Swami comes in all sorts of forms, and he offers you protection and love one way or another.